The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our August 19 Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. As we head into our 6th month under an emergency declaration, the first iteration of the recommendations from each of the governor's task force work groups is due to that larger body today. So we're going to spend some time on Friday discussing those items. There are a lot of issues there that are pertinent to our members. And we're going to talk about those on our Friday webinar, just to give you a little bit of an advance notice. This morning, we're going to be focusing on mostly recent CDC and MDHHS guidance and start with our routine agenda. And so we'll turn the presentation over right now to Dalton Herbal, who will provide a brief advocacy update.
Good morning, everyone. I do have just a brief update today. We'll be covering some new legislation that was introduced that will be setting up kind of the September legislative agenda for the House Republicans. Also in September, there will be the budget deficit negotiations, which I think will take up a majority of the space. But there are going to be some conversations going on beneath that. I wanted to provide an update to Michigan Schools solution that we presented on last week. Just a brief update there as some finalizations were made. And then we'll cover a brief update to the direct care worker premium pay FAQ. And that new FAQ that Deanna sent out on the listserv, want to say on the 14th, is also attached to the handout section of this webinar, along with the copy of the PowerPoint presentation. So first, we'll be looking at the new House bills introduced. All of these bills were introduced by House representatives who are Republicans. These will be setting up kind of the agenda for them in September. The first is House Bill 6106, and this would make it so that the governor would have to designate policy and executive orders by county instead of by region. As you know, she has been using the 8 HSAs for a lot of things, and this bill would make it so she has to designate those by county, which may be a good or bad thing, but I don't see her going anywhere near this bill if it reaches her desk. The next bill is HB 6111. I think I missed a 1 there. That would prohibit the suspension of a healthcare license for violating a COVID-19 executive order, unless it breaks any other rules, obviously. The next bill, House Bill 6124, would make it so AAAs have to perform background checks for employees, volunteers, or independent contractors if they have direct contact with any sort of a patient. And the last bill that I thought was important is House Bill 6126, and this is a duplicate of the Senate nursing home camera bill. This is the bill where they would make it so that people can install electronic monitoring equipment inside a resident's room if they followed the proper procedure that we talked about on previous webinars. Usually you'll see the chambers introducing duplicate bills when they want to get something done. It just makes it so the process can flow more freely and a bit quicker once they come up with a compromise. So this kind of signals the fact that they're going to be moving this kind of legislation in September. On to the school update. They came up with a compromise, the governor and the legislature, and it leaves most of the major decisions to local school districts and local school district boards, which has upset some local school district boards, but they have general approval and agreement between most of the major teachers unions, teachers groups, and higher level educator groups. And more specifically, it instructs schools to look at local COVID data to determine their teaching method. So it will be up to the local school district to determine if they want to do in-person versus online training, and if they're, or teaching, I guess. if they're going to be doing in-person education, they need to prioritize in-person instruction for K through 5. They also need to perform benchmarking tests at the beginning and the end of the school year, and schools must provide a learning plan to their school boards monthly that needs to be approved. These benchmark tests and some of the stuff later on, or on the bottom of this slide, apply to the school being able to receive funding. A school district must track and have two-way communication with 75% of their students each month. These attendance figures need to be publicly reported on a monthly basis, and a school will lose funding if attendance drops to 75% or below, but the funding can't drop to 75% of the total funding. And that's the overall funding is based on a mix of this year's attendance numbers and last year's attendance numbers. That way schools won't totally be left high and dry without some funds. Lastly, I wanted to touch over the direct care worker premium pay FAQ, just a brief overview. It is to provide $2 an hour increase for rates set as of March 1st. You may notice that March 1st is a little different than the June 30th deadline set in the FAQ, but it's just a difference between legislative intent and the actual implementation. The funds include all costs incurred by the employer, including payroll taxes, and they apply to the time period of July 1st through September 30th. I have been getting some questions about who is eligible for these payments. Eligible workers in a SNF include registered nurses, licensed practical nurses, competency evaluated nursing assistants, respiratory therapists, and ineligible workers include contract staff and administrative staff who do not provide direct patient care. The administrative staff did provide direct patient care and have a license to do so. They can receive this $2 an hour bonus. And you would want to send your applications for reimbursement to the testing email that I'm sure you're all familiar with by now. So what was new in the FAQ? It has to do with the base wage rate for this provider or premium pay. As you know, the payment will be determined by comparing wage levels effective July 1st to wage levels in effect on June 30th, meaning that the wages effective July 1st through September 30th will need to be $2 an hour over the wages that were in effect on the 30th. MDHHS added an exception to this on the 14th for those providers who were providing premium pay before the implementation of this and wanted to cancel that premium pay once they heard about the bill. So the new exception is that prior to July 1st, 2020, a nursing home scheduled premium pay to end on or after June 30th, but before July 15th, then the $2 an hour increase excludes the premium pay and is only above the base wage rate. And in more common terms, if an employee is paid a base wage rate of $15 an hour and is receiving a premium wage rate of $18 an hour, then the employee should be paid $17 an hour as of the date the premium wage expired. So if your premium pay ended before the 15th and you can have documentation that it was scheduled to end before the 15th, you can adjust it accordingly. And I do know some members do fall into this category. And as I said, you need to be able to retain documentation of the scheduled change.
All right. Thank you very much, Dalton. Right now, I do not have any questions. Maybe somebody will have a question while I'm going over this. Just wanted to let everybody know that we are holding our Leadership Institute this upcoming September 9th and 10th. I believe that is a Wednesday and Thursday. We do have registration open now. If you do download it, the link to register is right here, or you can go to our website, leadingagemi.org. wings2.org. And this banner right here will be the first thing that pops up. You can go ahead and click on that, and that will take you to our webpage with links to our sponsorship page and registration page. So we are pleased to invite each of our members to join us for our annual Leadership Institute. It will be a fully virtual conference that is specifically focused on access to the experts and policymakers who can help inform that new vision. We have focused on pertinent state and legislative updates, budget, financial and reimbursement trends, regulations and guidance, and networking opportunities. We want to help members overcome, persevere, and continue to provide the quality care that we are known for. This event has always been made special because of the fellowship that follows shared values and experiences. It is the collective spirit that holds us to mission and supports our strength through regulatory chaos, transformational change, uncertain politics, budget issues, and the pandemic. We continue to work to inform and prepare members to face again another unprecedented challenge to serving seniors. This event is supported by our members, but also through our valued business partners who can assist members by sharing industry solutions to some of our challenges. Participating in our virtual expo during the conference is a great way to thank our generous sponsors for their continued support. We do have our three keynote speakers, a couple main speakers here. We have Robert Gordon, who has been invited. He is the director for MDHHS. We also have Larry Horvath, director for LARA and BCHS, and Alexis Travis, the senior deputy director for Aging and Adult Services Agency for MDHHS. So like I said, you can go ahead and register now, and we hope to see you all there. Deanna, I believe you are up now.
Okay, well, thank you, Blake, and thank you, Dalton. We're going to have a very brief situation update this morning, and we'll start with a brief overview of the WHO daily summary for yesterday. It looks like some of the recent surge may be calming down a bit. Across the globe, there was a 1% increase in the 7-day average of new cases. And that's pretty significant in terms of overall numbers, but small in terms of transmission. And across the Western Hemisphere, we had less than a 1% growth in new cases. So that's a better sign as well. Deaths have decreased overall, but they have increased here in the West. The Americas, North and South America, continue to account for a large share of both caseload and deaths. This is also WHO data, and we have pulled this from a few of the more developed and impacted countries. In this group, you can see that the US continues to lead in the cumulative number of cases per million. And although there are several countries whose death rate per million do surpass the US, but we do have a significant number of cases and compared to most of the other industrialized countries. This is the CDC chart that trends the U.S. new caseload each day. And you can see that although we know there are several regions where cases are skyrocketing upwards still, overall we're seeing some downward trends, so that's very good news. This is our routine graph, the 7-day rolling average of Michigan new cases as of yesterday. And you'll see our average dropped just a bit yesterday. It's not clear that this recent uptick over the last week or so is starting to decline or not, but we're certainly hopeful that things will get a little bit more steady in terms of caseload increases. In terms of daily deaths, we definitely have seen some spiking over the past week. The next few weeks are going to be really important here in terms of trending both caseload and deaths because we're just beginning to head into the influenza season. So we're going to have to be very watchful, and persons might want to look at how much care they're taking in terms of transmission. Here is the MySafe Start map as of yesterday, and you'll see there's been no change. We continue to be at medium to high risk in most of the regions. In terms of overall cumulative caseload, you can see that we're getting close to hitting a 100,000 case benchmark, which is a little scary. If we look at the number of recovered, which is about over 67,000 or so, and add the number of deaths, which is about 6,300, we can see that we currently have about 20,000 active cases here in Michigan. So that's our brief situation update here in Michigan. And now we're going to move to resources and guidance, and we're going to start with the CDC. Actually, we've kind of sprinkled CDC guidance throughout the entire rest of the presentation. The CDC has been very busy in the last week or so. And keeping up with CDC guidance is a bit challenging at times. The website has a large number of subpages with repetitive and overlapping topic areas. So you really have to keep looking around. Some of these big issue areas are repeated in different parts of the CDC website, but they're often characterized and described a bit differently from web page to web page. And sometimes it's hard to get your arms around what the actual guidance is trying to say. So we find that that has happened a lot with use of N95 respirators. We're going to talk about PPE and N95s in a little bit. This guidance here is for management of patients, and it provides kind of an updated overview of some of the characteristics of the virus. And there's still a lot that is unknown about that virus. It's possible to become sick with the virus up to 14 days after exposure, but most persons become ill at around day 5. And people who do become ill, they generally do so within the first 11 days, although they can up to 14 days. We pulled out some of the list of symptoms in this guidance because we have some questions about which list to use when screening residents and staff. There's a couple lists on the CDC websites. There's a list on the MDHHS website. And again, I think that we should really kind of think about them all together. We should use all of the symptoms. We didn't find any real significant differences in these lists. They're tweaked a little bit from page to page. We do know that many persons will not necessarily present with respiratory symptoms, and that's an important thing to remember. And that in many people, loss of taste or smell often precedes respiratory symptoms. So you can use that as a guide, perhaps, to catch a case very early. Some have GI complaints, some have muscular aches and headaches. The predominant number of people still have respiratory complaints, but it's not required at all. So these symptoms are so extensive that it can be hard to screen residents, but it's really important to evaluate your residents every day since early detection is critical to controlling spread in your facility. This same guidance reflects that there's still so much unknown about how much asymptomatic disease there might be out there and how can we detect pre-symptomatic infection. It's not clear at this point where in the incubation period persons will actually test positive, and that's part of the problem with figuring out who is got the disease and who doesn't. The guidance notes that some persons actually have chest X-ray abnormalities before they have any symptoms. They do know that there's been some transmission before symptoms, though. That's been very clear. And they continue to be unsure about how infectious someone might be, even though they might still be shedding virus and testing positive. They do know that most people are most infectious in the first 5 days or so after they have become symptomatic. So in this guidance, they identified categories to measure illness severity. And they use these illness severities levels in different ways. They use some of them in terms of looking at how safe it is for someone to return to work, and they use a little bit more detailed set of categories for determining when you can discontinue transmission precautions. So we're going to talk about that in a few minutes. 81% of the cases to date have pretty much fallen in the mild to moderate category. And in the critical category, almost half of the persons there have died. So over the weekend, the CDC updated its return to work criteria for confirmed positive staff, or for those with symptoms who were not tested. These recent updates refer to persons with symptoms and not tested, and that's kind of a new thing. It was hard in my mind to get around that idea and even think about a scenario where that would happen very often. I would think that any staff person in a facility who looked symptomatic at this point would have to be tested. But anyway, these updates are mostly related to focus the preference, the CDC's preference on symptom-based criteria. And that's, probably been pretty consistent over the past month or so. Obviously, any staff with symptoms need to be prioritized for testing. They suggest a repeat test if someone has symptoms strongly suggesting they have the virus, but the first test was negative. When COVID has been ruled out, a person can return to work based on the status of any suspected reason for the symptoms. In other words, if COVID has been ruled out, they can return to work, but only if they're not infectious in some other way. Persons with symptoms from respiratory viruses that are not COVID-related should still not be working with residents. Return to work considerations also have to be made in context of the local situation. And of course, a test-based strategy is only recommended in a very few situations at this point. The updated return to work criteria simply categorize the symptom-based strategy for staff who have mild to moderate illness from those with severe illness or who have been immunocompromised. Oddly enough, it seems that these categories of illness severity that have been defined here are used for return to work. But there are more detailed illness severity levels that the CDC uses to categorize patients. So that's a bit confusing, and we'll cover that in a bit. But these definitions, as they're stated on this slide, have not changed. Changes were made in this guidance regarding the use of test-based strategies for return to work. The CDC still allows the use of test-based strategies, but they don't recommend it. They do believe that in some situations, it might get some persons back to work earlier, but more often people tend to test positive for longer periods than they're actually infectious. And of course, test-based strategies are required to be used for persons who are severely ill or significantly immunocompromised. But for symptomatic staff, if fever has resolved without medications and symptoms have improved, they can return to work after 2 negative tests that have been done at least 24 hours apart. That is an option that you have. Chances are, though, that they're going to test positive longer than they're actually infectious. So the symptom-based criteria might be more helpful. One of the things that they have changed in this guidance is the test that you use has to be a molecular test. It cannot be an antigen test for this purpose. So if the staff was asymptomatic and you're using the testing criteria, that also must be a PCR test and not an antigen test at this point. You can see in this criteria that all symptoms do not have to be gone in order to return to work under the test-based criteria. And if staff still have some lingering symptoms, they must wear a surgical face mask at work. Most direct care staff do wear face masks rather than cloth, but this would also include persons in non-direct care roles in your facility. They must wear a surgical level face mask at work until all their symptoms have gone away. The CDC also included some small updates to its guidance on discontinuing transmission-based precautions. Again, the focus is still on using a symptom-based strategy for that. And again, the time period for discontinuing precautions is based on the severity of symptoms and disease that we discussed earlier. And this is the part where they use a little bit different description, a different type of description for these severity levels. This guidance notes that in order to discharge from a hospital or a nursing home into the community, the patient does not have to meet the criteria for discontinuing precautions. In other words, they could be infectious. They do note that the timing for viral shedding varies greatly individual to individual, and they're not sure why that is yet. If you have a patient who falls into the category of severe or critical illness, in general, it's considered they can be managed and isolated for about 15 days. But the CDC suggests that you confer with an infection expert before discontinuing precautions for someone with this significant level of disease. So the updates to this guidance also focus on the fact that you can use test-based strategies to discontinue precautions. And you actually only need one negative result using a PCR test once you've already tested positive at some point. So if a patient continues to have significant symptoms and you're concerned about that, you can repeat the test before discontinuing isolation. But you have to remember that there are false negatives even in PCR testing, which is why you might want to do that. The decision to send a person home is a clinical decision, and it can include many factors. If there is a discharge from the hospital to a nursing home or assisted living center and transmission-based precautions are still needed, the hospital has to determine that the facility must be able to adhere to infection prevention and control recommendations and preferably have a dedicated area. So these are the categories for illness severity that the CDC uses to characterize patient disease. So note that these were a little different than we talked about staff and the return to work. These are much more clinical. And they're used to identify the length of time for isolation for recovering patients. The CDC notes that the studies that they used as basis for this guidance didn't really define severe critical levels of the disease. So they've decided to use the National Institute of Health criteria for COVID. And it's important to note here that the category is assigned if the patient had any of these clinical factors at any point during the infection. So if they have one really bad day where they have really significant respiratory problems, that puts them in a higher level category immediately. Persons with mild disease generally have no respiratory symptoms. Moderate disease level have some level of respiratory disease, but it doesn't impact their overall oxygen levels. Severe illness, that category starts with really significant respiratory symptoms, and the critical category is really used to identify persons who have gone into some form of shock. They have a separate category for immunocompromised persons, and they note that that designation really has to be decided by the treating physician, but they have added some additional detail in this category. They continue to identify that basic risk factors for severe illness, such as advanced age or diabetes alone, those will not necessarily mean that someone is immunocompromised, and they shouldn't impact decisions about discontinuing precautions. It really is the clinical conditions as identified on the slide here that would be considered. So last week, the CDC put out a study about testing in nursing homes, and they found that when doing blanket testing in nursing homes that had not had a previous case, so in a whole jurisdiction, a health department tested all of the facilities, and none of them had a case, a current case. The percent of positives found overall was 0.4%. But if one case had been found in any of those nursing homes in their jurisdiction, the number jumped to 12%. And for each day that testing was delayed, another 1.3 cases on average were found. So this is their strong case for rapid and complete testing whenever a case is found in a nursing home or in the area. So we're going to move on here a little bit to our LARA updates. They did update their frequently asked question guidance for HFAs and AFCs. There were really only a few changes here. We will review some of the essential pieces briefly, though, just as kind of a reminder. Most of the changes were really simply about updating the number of the executive order that they were referring to, but there were a few nuances as well. They always start their FAQs with a list of recommendations about minimizing spread, and they refer to the CDC infection control guidance, the link that's included here, and none of that part is new. A reminder that EMS staff do not need to be screened if they have to enter your facility. They are screened daily on their own. And the FAQs also go through the thinking about whether to accept a COVID positive person back into your facility. They want you to consider if the person meets the criteria to discontinue transmission-based precautions. But they also include here a piece about being fever-free for 3 days. And that's very old CDC guidance. It's not been updated here. So I would look at that and perhaps use the CDC transmission-based precaution discontinuation guidance. So another question is, can you effectively isolate and care for the person? Do you have the medical coverage needed to care for this person? And they continue to provide a link to the MDHHS transfer tool for guidance about placement. The FAQs spend a lot of time talking about pre-employment and ongoing staff requirements. TB testing could still be deferred, but they do suggest it be completed ASAP. It also extends certifications for basic and advanced life support. They will now accept online CPR training during the pandemic, but if you are delaying some of these things, you still need to screen persons for any pre-employment issues and ensure that they're competent before being scheduled alone. And that's really pertinent for some really small facilities. Even when just gathering the required paperwork, you need to ensure that they are safe and competent before being left alone. Fire drills, we know, can be difficult with residents and social distancing, so they can be done with staff only, or you can just ensure that your staff are trained with fire drills. They do note here that the Bureau of Fire Safety has resumed routine inspections, though. Licensing staff is starting to do renewals, and some may be done on site. They will be contacting facilities to discuss this individually. Licensing staff will be coming in with masks and gloves, but if more PPE might be needed, they ask that the facility provide it. Admissions, of course, were never banned, and this is not new. Admissions should be quarantined based on CDC guidance, as well as anyone who's returning to an HFA or AFC from a hospitalization. You must have someone in authority authorizing a quarantine for a symptomatic resident. The other pieces you can put in your overall policies and guidance and resident admission contract. but putting someone in quarantine for symptoms is not a violation of resident rights. So that's important to know as you move on, but you do need to have someone in authority authorizing it, meaning a physician or a local health department for symptoms. Of course, residents can leave the facility at any time. That's not new. The facility is expected to educate on social distancing, masks, and any other directives. You do have the right to screen persons on return to determine whether or not there's any risk based on their contacts, and you can consider requiring a quarantine. But you do have to allow that person to return to your home unless, of course, you suspect that they really have COVID, and then you must isolate them and test them, get an order for some testing. For any potential discharge notices, there are still discharge rules, and those are in Executive Order 169. For facilities, I'm sorry, please go back, Blake. For facilities whose license is up for renewal, an extension letter is being sent. And they ask that you give the department 2 weeks after the expiration date to get that letter. If you haven't gotten it by that time, there's a number you can call to request a letter if you haven't received one. Again, non-essential construction is only allowed in separated areas from resident areas. And if you do need, have to have some construction in a resident area, workers must be screened coming in and out of the building. And last but not least, this doesn't make a whole lot of sense to me, but apparently HFAs have to submit an incident report if a staff person has been found positive, but AFCs do not. I did not note that in the previous FAQ. It may have been there, but it kind of stood out to me as we reviewed that. So that's an awful lot of detail and stuff. So let's pause for a few questions and comments before we move on to a discussion about antigen testing.
All right, thank you very much, Deanna. Before we get to those questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association, but your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Now, I do have a couple questions, so let me pull those up really quick. All right. If a new admit had COVID recently and recovered per CDC guidance, do they still need to be quarantined for 14 days on admission?
Yes. The CDC would tell you that they're not sure about the time of immunity. They are not sure, in fact, in some cases, if there's any immunity at all. They do think that there might be some immunity, but they don't know how long it is. So I think that they would tell you that you still need to quarantine that person.
Okay. For independent living as part of a CCRC, but in a detached building, can those residents leave the building and or receive guests on outdoor visits? Can building improvements be done, as in carpet replacement, etc.?
Independent living, whether it's detached or not, is not allowed to receive any guests. However, you can't stop your residents from leaving. I think that a gray area is whether or not you can allow them to have visitors on campus. I think that I did hear that one surveyor was concerned about on-campus visitation. Obviously, if they have the right to leave your facility at any time. So they can visit with anyone they want outside of your building, outside of your campus. I would be concerned about allowing visitation without some sort of barriers on your campus. but there is no clear guidance about that either way. And I think that from what I hear in the communities, people are doing different things about that. I do think that in some areas for non-independent living, I do know that that would not be allowed. Independent living, I think that you'd have to use your own judgment. I would make decisions based on community transmission. I certainly would be concerned if you had any cases on your campus at all, but there is nothing that specifically says that the visitation guidance has to be directed on whether or not you have visitation in the building or on your campus. That's not clear.
Okay. Previously, it was told to us, and the surveyor made sure that this happened, that any resident who went out even for an appointment had to be put into a 14-day quarantine. Is this now not required?
My understanding is that that's not required. I would have to go back and I believe in one of the MDHHS guidance, it says that. In fact, I think it says that in a guidance that we're going to talk about in a few minutes. I think that what I have to think about is whether or not that was for nursing homes for AFCs or HFAs. My understanding is that people who are moving in and out of a building, such as for dialysis, even an ER visit, that screening is the only thing that you really need to do on return. They don't need any other quarantine time. It is important perhaps to make sure that you screen people thoroughly and talk about who they've had contact with to determine some risk. But my understanding is that you only have to quarantine people who are new admissions or a returning person from a hospitalization or someone who's been out for a significant amount of time, not for a simple medical appointment. But I think that we're going to review a guidance about that later, so but I'm pretty sure about that just the same. We'll wait till we get to that slide and I can remember better whether or not that's for HFAs, AFCs, but I think it's for nursing homes as well.
Someone did just confirm and said, yes, that is outlined in one of the guidances. You don't have to quarantine after going out for appointments, ER visits, dialysis, etc.
Right.
All right. It looks like that was the last question, so we can go ahead and move forward.
Okay, good. So, can you hear me?
Yep, you just cut out there for a second, but you're good again.
Now and then my phone cuts out. I'm not sure what that's about. We're going to talk about antigen testing guidance right now. And I do know that it can be a little confusing. It's a little complicated. We did talk about CDC guidances earlier, but I wanted to include both the CDC and the MDHHS planning discussion in this part. So we pulled the CDC guidance out to review it separately. So the CDC put out guidance on Sunday for antigen testing. And they talk about the different uses that tests can be cover. So there's diagnostic testing, which really is the need to identify a current infection, usually for someone who has symptoms or exposures. There's screening testing, and that works to try to identify generally asymptomatic positives. But you could also be screening for positives if you have an outbreak somewhere in your facility. The idea is that for screening is always to control the disease as quickly as you can. And of course, the last is surveillance testing, and that doesn't have anything to do with us. It's usually random and de-identified testing done by health departments. So antigen testing is generally used to diagnose, and these tests have now been approved by the FDA for that purpose. They look for a protein on the surface of the virus, and it's this protein that causes the symptoms that people get. A molecular or a PCR test looks for the genetic material from the actual virus. So these two different tests are looking for different things, but they both will tell you if someone currently has the infection. Antigen tests are inexpensive. They can be conducted at the point of care. They're very fast comparatively in terms of results, but they are less sensitive than viral or PCR testing when it comes to being accurate. So these tests are perhaps considered most effective when you believe someone may be in early stages of infection, and that's when the viral load is the greatest. So it's going to be easier to find that positive. So you can identify someone quickly using this test who may have the disease, and then you can act quickly. It can be used for persons with recent exposures. Those two are the primary purpose for this test. It's not the test of choice for screening, even in high-risk congregate settings. The CDC does state that you can use it to determine the amount of spread in a facility when you know you've got COVID residents there. But that only works as long as you plan on doing repeat testing over time for a while. Because of the number of false negatives, repeat testing helps the test be more effective. There's limited information on its use as screening tests for asymptomatic persons, and that's what nursing homes are doing now in their weekly testing. They're looking for asymptomatic persons among the staff, and therefore this is not the test of choice for that. The gold standard is still the PCR test. And you should even consider following up any testing that you might do with an antigen test with a PCR test if the result is inconsistent with what you think is going on with the person clinically. And if you do follow up with a PCR test more than 2 days after the antigen test, it's not considered a confirmation test. So you have to do that follow-up test within 2 days. If it's used for screening in any congregate setting, results have to be considered presumptive and not confirmed. And screening here means two different things. You could be screening for positives when you know there's a lot of transmission going on. If you have an outbreak in your facility, if you have even one case, you could use a PCR test to rapidly test everyone and figure out where the positives are, because it's very good at finding the positives. But you have to consider all of the findings presumptive. So you can't really say that it confirms it, but the likelihood of a positive being wrong is very small. The CDC, and this is where it gets kind of complicated, the CDC considers the probability of whether or not someone has COVID when it looks at what you should do in terms of the result of the test. So if a person has strong symptoms and the antigen test is positive, and you're in a high transmission area, you don't necessarily have to repeat testing. But if the probability of having COVID in the area is low, and you're using an antigen test that's positive, you should still isolate that person, but you might want to confirm with a PCR test. We need to note that there are very few positives that are false. There are very few false positives, but it is possible. If the test is negative and the probability for COVID is low, you also may not have to confirm with a PCR test. These are all clinical decisions that really your clinical team has to make. PCR tests are also considered presumptive when screening asymptomatic persons because they're more accurate, but there's still some false negatives there. So all of these tests are more or less accurate, but there's always room for error in any of them. And of course, you would have to report any positive antigen test as you would any other. So I think we're on the wrong slide. We should be on, there we are. This grid identifies the differences between PCR testing and antigen testing. The benefits are cost, timing, but you'll note that you lose some of the sensitivity of the PCR testing. I don't think there's anything really new here. The specimens are similar. You can do an antigen test with a nasal swab. You're looking for different material, as we talked about before. And basically, antigen tests can be very, very helpful in identifying whether or not you have residents or staff with disease quickly and cost effectively. So this is the grid for identifying the probability of COVID when thinking about the results of an antigen testing. And it seems a bit complicated, but it really makes sense. Clinicians should use these parameters to decide whether or not to follow up with a PCR test and whether or not that's needed. We won't go through this algorithm now. It's not complicated, but you'd have to do some thinking about, again, are you in a high or low transmission area? Is there a high probability that this person is positive or negative? If that's the case, then you don't necessarily have to follow up with a PCR test. If the clinical symptoms or the probability doesn't match the result of the antigen test, then you should consider repeating it. So on the 12th, which I guess is what, about a week ago, MDHHS held a conference call about antigen testing. And they clearly state that the antigen tests are not intended to replace PCR testing, but again, can be extremely helpful in some circumstances, and they identify those. Symptomatic persons in areas of high transmission. If you've had an outbreak, which means just one new case in your facility is an outbreak, and you want to rapidly test everyone, that's a good effective use of it. To triage care and services, to be honest with you, I don't get that one so much. Excuse me, it can be used for ongoing testing in facilities where there are known cases. So you can use them like weekly when there are known cases to watch the spread, because it will clearly identify positives. And you can use them in remote areas where PCR testing is hard. But it is not meant as screening for asymptomatic individuals such as staff on an ongoing basis. So last week, MDHS HHS also updated the SNF testing FAQs. And there were only really 2 issues updated, and they were pretty small. And the first one, the caller was right, does the testing requirement for all new or returning residents during intake being tested within 72 hours include dialysis, doctor visits, or ER visits? And the answer is no. So we confirm that. Can facilities submit for reimbursement that occurred prior to the executive order? And the answer to that is yes. You can submit information for reimbursement throughout the entire time of the pandemic, ever since that she declared a state of emergency on March 10th. So any testing expenses that you've incurred related to that can be submitted. So the other, no, please go back. So the other piece that we talked about a little bit last week is a directive from MDHHS. It's called the Guidance to Protect Residents of Long-Term Care Facilities for Readmission and Recurrent Stay. And this is the infection control requirements that you have to have no matter what kind of a facility you are. And this is the grid of PPE requirements that we thought was significantly out of date. one of the things that they say in this guidance is that, and this is not new, continued hospitalization until a resident can be tested is counter to testing criteria. And basically that certified nursing homes have to comply with CMS and CDC guidance, and long-term care facilities overall have to be screening everyone coming in and out of the facility except for EMS. But the bulk of the changes in this guidance is specific to updates for the use of PPE. And these are really significant changes for MDHHS since the beginning of the pandemic. It felt to me at least that their guidance was quite different from the CDC guidance at that time. But now that things have changed, they come a lot closer to what the CDC is saying. They do continue to have a paragraph right before this complicated grid that says the N95 should be reserved. But you'll note in the grid that they are finally listed for both transmission-based precaution and standard care. And we can only assume that they've done this because most of Michigan has substantial transmission at this point. So this grid, there's actually, I think, 4 or 5 grids in the guidance. It summarizes the PPE requirements for all settings. The only difference among these settings is the asterisk yes under gloves. That's the only difference between any of these settings. And all of the settings are covered here. Nursing homes, assisted living, AFCs, HFAs, and independent living are all required to use this level of PPE for each of these categories. The first category being transmission-based precautions. The second is standard precautions for daily care. And the third category is on entering the facility. So N95s are recommended for all care activities, and surgical masks should be used if they are not allowable. That's true in all settings. The guidance now says that surgical masks for caregivers should be worn on entering the facility. It used to say cloth. Cloth masks are never appropriate for care, but they can be used on entering the facility and for non-caregivers. Eye protection, this is the part that they have now updated based on CDC guidance. Eye protection is now required for transmission-based care and is required for all care in areas of moderate or substantial transmission, which right now is the entire state of Michigan. And this, again, is in alignment with CDC guidance. Gowns are required for COVID care and for standard care if splashes or sprays are likely. Sterile gloves are not required in general, but gloves are required for transmission-based care and any regular care where contact with blood and body fluids is anticipated. And that again is in moderate, for activities where contact with blood, body fluids, and infection materials in lower level settings is always required in the nursing home for gloves. So the CDC also put out some new guidance this week for senior precautions and the risks. One of the most important pieces of this guide I thought that was helpful is perhaps how to consider in-person visits with family or friends. They note that there's always some risk, that no senior right now is without some level of risk, but that particular precautions should be undertaken and risks reviewed before considering. And some of the issues are, can you keep socially distant? Will you be indoors or outdoors? Wear masks. So the CDC still believes that there's an awful lot of risk for seniors. There's an awful lot of transmission going on out there, and so they put this recent guidance out to kind of identify those concerns. With that senior guidance, we included this because it just looked kind of interesting. CDC included the risk for death and hospitalization based on age. And you can see that this is major, that an 85-year-old person has 13 times the risk of an 18 to 29-year-old for hospitalization and 630 times the risk for death than an 18 to 29-year-old. So that they want to make sure that seniors really understand that the risk level for them, just based on age, is considerable. A few days ago, the department put out a new policy, MSA 2056, and this is just to address the changes that the governor included in Executive Order 161. Basically, out-of-state licensure flexibilities are no longer allowed. So you used to be able to just use someone from out of state if they were in good standing and licensed in another state, but that's no longer allowed. RNs and LPNs on their own can no longer order COVID testing. And the normal rules for delegation and supervision of advanced practice professionals, such as nurse practitioners and such, have been reinstated. CMS is providing a new series for COVID prevention for nursing homes. This is intended for nursing home management. It might be also helpful for HFAs and AFCs. These are pre-recorded learning sessions starting next week, and they include a bi-weekly live session, live interaction with experts. So this might be something that's very, very helpful. The links for registration are there. CMS this week also issued notice that nursing home inspections will go back to routine. They will be resuming annual recertifications and revisits and plate surveys. In terms of guidance for enforcement actions that have been put on hold, they have prioritized cases into 3 groups based on timing. They've also expanded, though, their desk review policy, which will probably be quite helpful, so that you can do a desk review for all non-compliance reviews except for immediate jeopardy, if that immediate jeopardy hasn't been reduced to a lower level citation. Providers now have 10 days to submit any plans of correction that haven't been submitted for any surveys that had an exit before June 1. Facilities, nursing homes can ask for an extension if you're coping with high COVID caseload or something related to that. One important thing to note is that surveyors can include the clinical area of concern for any harm or immediate jeopardy level citation that had been lowered that was addressed during a desk review. They can include that review in their next on-site survey. So even though you're getting a desk review, you should anticipate that they're going to review the clinical area as well later. And they have this complicated plan for enforcement actions that you might want to review. It just seemed too detailed to go through here. The link for the S&C letter is included at the bottom of the slide. So that concludes all of the details for today. Blake.
All right, thank you very much, Deanna. Again, Leading Age Michigan would just like to thank our business partners. Here is a list of some of the exhibitors for our postponed annual conference who have stuck with us throughout all of this. If you are considering a purchase of goods or services, please remember this name, this page of names, and then this next page as well. I will actually move forward to that as well. Another list of our exhibitors here. So if you are considering on making a purchase, please make it from one of these fine organizations. Now give me 1 second while I pull these questions up. All right. If a staff member tests positive and HD recommends to retest twice greater than 24 hours, is that positive considered a false positive? Also, do we need to continue weekly resident testing based off false positives?
Okay, I'm sorry. You're going to have to, let's take it one at a time. Start with the first question.
Okay. If a staff member tests positive and HD recommends to retest twice greater than 24 hours, is that positive considered a false positive?
No, it's not a false positive, but it means that the person is still shedding a viral shedding. I guess I would be concerned about a health department that was, unless there was a reason for them to require a test-based strategy. The CDC recommends a symptom-based strategy. And we know that these staff persons are going to test positive, some of them for a very long time after they're no longer infectious. So I guess I would question that, and if that's an issue, I would want to talk to the state health department. It's not a false positive. They actually are, if they've been positive, likely shedding virus, but they are not necessarily infectious. So my concern would be the use of a test-based strategy at this stage of the pandemic.
Okay, and then the
second part of that question?
Yep, the second portion of that question is also, do we need to continue weekly resident testing based off false positives?
Well, the likelihood of a false positive is almost nil. So I would never assume that you have a false positive unless you've retested and you get a negative. So until you've confirmed that the person doesn't have the disease, if a person is a positive, you have to assume that they're positive. So the answer would be you have to continue weekly testing of all of your residents and staff until you get 14 days with no positives.
Okay. Is weekly testing just for staff or staff and residents? I have heard different things from different people.
Right now, considering the state of transmission across Michigan, you have to test all staff weekly. You do not have to test residents unless you have some positive findings in your facility. So, and they have to also be facility acquired. If you get an admission that's COVID positive and you put them in a dedicated unit or a private room, you do not have to test your residents. But if you have a COVID positive person and that was acquired in your facility, then you have to test both staff and residents until you have no more positives for 14 days.
Okay. So visitation will be allowed if we follow the stipulations you mentioned. What EO was this listed in?
There are no changes to visitation. The only thing that I think we were talking about was a gray area when it comes to the definition of visitation for independent living. I do know that for nursing homes and other areas, being on campus is considered visitation, but we do know that some people have done window visits. So it's a gray area. There have been no changes in visitation. Right now, and I don't remember, because I keep changing the executive orders, I can never keep up with the current number. But the visitation guidance includes nursing homes, assisted living, HFAs, AFCs, and independent living, and there is no visitation allowed. But does that mean because you cannot constrain someone, you can't restrain them from leaving your facility, does that mean they can't visit on your grounds? That's the gray area.
Thank you. Is the waiver which allows SNF beds to be duly certified still in place?
Oh, I have to continue to look at that. I did forward that question to Dave because he is much more knowledgeable about that. I do know that someone asked me that the other day. We will look into that. I will continue to work on that.
All right, thank you. Right now, it looks like that is our last question for today. If any other questions do pop up, if you think of anything later, you can go ahead and shoot an email to any email here. We have Safe and Calm. Multiple team members will see that. You can also go straight to Deanna Dalton or Laura Funch.
I would like to remind everyone, Blake, that the task force, which might, will have recommendations going to the governor about how to deal with what we consider to be the high probability of a fall surge, how we will treat and deal with regional hubs, how we will deal with visitation and testing, etc. All those things are up in the air and being rediscussed. We will cover the state of that discussion on Friday during our 11 a.m. webinar, just as a reminder.
All right, and I actually did have one more question pop in while you were doing that. Any updates on allowing hairstylists in?
No, they are still not allowed. Sorry.
All right. Well, thank you for that. We would like to thank Dalton and Deanna for all the information today. We would also like to thank all of our members and participants. I believe we had up near 80 people that took time out of their busy schedule to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As Deanna said, our next Safe and Calm webinar will be this Friday at 11 a.m. Eastern Standard Time, so you will get the reminder email as always, and we will see you all then. Thank you and have a great rest of your day.